Thank you everyone for joining us. It takes Zoom a minute or so to add everybody into the room, so please sit tight. We'll get started in just a few moments. Thank you. Hello everyone, thank you for joining us. It takes Zoom about a minute to add everybody into the room, so please sit tight. We'll get started in just a few moments. Thank you. Okay, it would appear that Zoom has had time to add everybody into the room, so we will go ahead and get started. Thank you everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic and its effects on society. I'm Gregory Phillips with Duke Communications and I'm moderating this event. The overlap of the COVID-19 pandemic and the upcoming flu season could very well worsen the ongoing and already catastrophic public health crisis. We have three Duke scholars with us today to discuss the potential impact of flu season during the pandemic and why getting vaccinated against the flu is especially important this year. I'll introduce our speakers and get the discussion started, and then we'll open it up to questions. We are recording this briefing, and that recording will be sent to everyone who registered. Thanks to those reporters who already sent questions. During this discussion, those of you joining us on Zoom can submit questions via the Q&A window at any time. There will also be an opportunity to ask questions in person in a few minutes. Thanks also to everyone watching this on YouTube. With us today is Thomas Denny. He is Chief Operating Officer of the Duke Human Vaccine Institute, a Professor of Medicine at Duke University Medical Center, and an affiliate member of the Duke Global Health Institute. Good morning.
Good morning, Greg.
Also joining us is Lavanya Vasudhavan. She is an Assistant Professor in the Department of Family Medicine and Community Health and an Assistant Professor of Research at the Global Health Institute at Duke. Good morning to you.
Good morning, Greg.
And although he's not with us yet, shortly joining us will be Dr. Mark McClellan. He is a physician and economist who directs the Duke-Margolis Center for Health Policy, where he works on strategies and policy reforms to improve healthcare. He was previously Commissioner of the US Food and Drug Administration and an administrator of the Centers for Medicare and Medicaid Services. And as I mentioned, he'll be with us in just a few moments, but we'll go ahead and get started. And Professor Denny, I'd like to start with you. With this flu season coming during a pandemic, why is it particularly important that people get the influenza vaccine this year?
Well, it's important this year and every year that people take a flu vaccine, and especially this year when you have COVID circulating. Both infections affect the respiratory tract and can have serious consequences, especially to those that are predisposed for any underlying medical events. If we can have a high vaccine take rate, if you will, this year for influenza, we can help to reduce or sort of take that infection or that disease, if you will, off the table and minimize the consequences that result from flu infections by increasing our overall vaccine effectiveness this year.
Sure, that makes a lot of sense. Thank you. Professor Vasudhavan, data from earlier this year already showed that vaccination rates in general had dropped after the pandemic shutdown began. What can be done to avoid that shortfall continuing through flu season? And are there any signs that it's picking back up yet?
Yeah, thanks for that question, Greg. I think just to give some context from a public health perspective, we are going into this flu season with both hands tied behind our back. We are contending with, like you said, the drop in preventive healthcare visits, drop in vaccination rates due to COVID-19. And we are also working in a climate where trust in vaccines continues to erode. As Dr. Denny mentioned, even in the absence of COVID-19, flu vaccination is something that we struggle with every year. North Carolina actually does much better than most other states, but still only 1 in 2 people in NC get the vaccine each year. Last year, we saw flu outbreaks throughout the US, and this year in the context of the COVID-19 pandemic, the stakes are just much higher because we are risking a twindemic. So unless there is a valid medical reason, anyone 6 months of age and above should be opting for the vaccine. To answer your question, some strategies that have been used in the past to promote flu vaccination are communication campaigns, which are primarily aimed at increasing awareness about the vaccine. There are also efforts to make sure the flu vaccine is available at convenient locations like neighborhood pharmacies, providing vaccinations to health departments, FQHCs, through public health insurance programs for uninsured individuals. So what the state public health agency is doing this year is really stepping up those efforts on all of these fronts. So increasing awareness, increasing convenience, just because the stakes are so high. And if we don't get good coverage of the flu vaccine, we are looking at compounding deaths, hospitalizations, and infections due to the double impact of flu and COVID. And that should not be an acceptable scenario for anyone.
Sure, absolutely. That makes sense. Thank you. We've got lots to dig into here. And while we're waiting for Dr. McClellan, I want to stay on this, this flu topic. Dr. Denny, we had a question that came in from Voice of America, which asks, points out that apparently the flu season in Australia was mild this year. Does that give us any hope or indication that it won't be as bad in the Northern Hemisphere this year?
Well, it could be, but it's also important to recognize that the folks down under have been under mandatory mask wearing and lockdown through their winter season. So we know that there are a lot of benefits to flu with anything you can do to minimize droplet exposures. Hand washing, all of those sorts of easily adhered to techniques. So I'm cautiously optimistic. If we in the U.S. follow masking and follow distancing throughout the flu season, we should realize improvements in reduction in flu and in reduction in potential exposures to COVID.
Gotcha, absolutely. Thank you. Professor Vasudevan, one of the concerns that obviously people have about flu season is the potential for hospitals to become overwhelmed if people, if too many people are getting sick with the flu because they're not vaccinated on top of the pandemic. Is there any suggestion to show that that kind of warning or that kind of fear can help combat vaccine reluctance, that that's a message that could get through to people? And do you think that's something that should be emphasized when people are kind of trying to push forward the flu vaccine this year?
Yeah, I think that's a great question, Greg. And if I can back up a little, there are many reasons why people don't get vaccinated. And in the research world, we often talk about these using the 3 C's model. So we talk about complacency, convenience, and confidence. I think what you are talking about relates more to the confidence issue. I think we have the challenge that the flu vaccine is not always the most effective vaccine. So people use that as an excuse to not get the vaccine. There are also a number of myths associated with the flu vaccine, like getting the flu vaccine will actually give you the flu, which is not possible because the virus particles in the flu shot are dead, so they cannot multiply and give you infection. So I think at the base of all this, it's important to remember that flu is a contagious respiratory disease, and serious infection can lead to hospitalization or death. So even in a situation where the vaccine is not fully effective at preventing flu, it can help reduce the severity of infection. And absolutely, it helps to tell people that, because when people think vaccine is not effective, I don't see a reason why I should get it. There is a reason why you should still get it. And sometimes I use the analogy of wearing a seatbelt or a bike helmet to explain this. If you're in an accident, a seatbelt or a helmet can prevent serious injuries or death. So it's the same with the flu vaccine. Even if a flu vaccine doesn't necessarily prevent you from getting the flu, it can reduce serious negative consequences of flu infection, like hospitalization and death.
Gotcha, thank you. And Professor Denny, do we know much about the composition of the flu vaccine this year? Is it one of those things where we have to wait till the end of the season to know how effective it was looking back? Or are there any predictions we can make based on the composition of the vaccine before the season begins?
So I think we start each year with a lot of optimism, and I'll defer to our former commissioner of FDA there. But the way we guess at, if you will, or we look at what's happened in the Southern Hemisphere, and then we try to predict what's going to be needed, for the Northern Hemisphere. There's a little bit of a prediction and a guesswork with that. We're getting better at times, but also there's been years that we haven't been so good at that guessing game, if you will. So I think I tried to look for numbers the last day or so. I have not seen anything yet out there by CDC or others that have sort of said, okay, how close did we get it for what we think strains will be circulating in the U.S. this season? But in recent years, we've been anywhere from probably a low number of 20% hit, and we've been as high as 65% successes, I think, if you go back over the last 10 years. So hopefully we're higher to the 60% and 50% area this year.
Sure, absolutely. Thank you. And welcome, Dr. McClellan. Glad you were able to join us. And since you're here, and as Dr. Denny mentioned, you're a previous commissioner of the FDA, I wanted to pivot a little bit to talk about the latest with regards to a COVID vaccine. Now, we know that in 2004, Congress authorized the FDA to grant emergency authorizations for medical treatments of vaccines in certain situations. Can you tell us how that fast tracking process works and how likely it is that we might see an emergency authorization for a COVID vaccine?
Sure, happy to talk about that. Let me first say that just to pick up on the comments about flu vaccine, we're looking ahead to COVID vaccines potentially available in just a few months for at least some Americans, not most, but some. But in the meantime, it is now the time to be thinking about flu vaccination. And if we can get vaccination right for flu, that's a great practice, great warm up for doing an effective job on the challenges ahead with a COVID vaccine. As you said, the first uses of a COVID vaccine are probably going to come under this FDA authority called Emergency Use Authorization. And that was created, as you said, back in 2004. I was commissioner of the FDA at the time, and the motivation for that was really 9/11, the anthrax attacks, the concern that there could be a big event involving a biologic agent that could really be disruptive for the country. And the thinking was that we've got an FDA approval process that works well for threats that we understand. We have accelerated approvals for unmet medical needs for cancer, for other conditions. But what you worry about with these public health emergencies is a big threat that's unprecedented, that can potentially have big consequences for the American public and may not be well suited to just the usual ways of doing a product approval. And what we built into that EUA model was a flexible approach, one where if there was, it depended on the risks and benefits based on everything we knew about a medical product for different populations that might benefit more or less from it. And it was established in 2004. It was modified in 2013 after our experience with the H1N1 flu pandemic. And a reminder that pandemics are also very big public health, it can be very big public health emergencies where kind of a rapid response is needed, but you don't want to inappropriately or compromise regulatory standards. You just want to recognize that there may be some new treatments that have real benefits for certain people. And you want to recognize that since you're dealing in kind of emergency pandemic timeline, that you need to put a lot of emphasis on learning along the way in kind of a big coordinated federal response. And that's what we're seeing happen here. I think some people understandably have some nervousness with the speed of vaccine development for COVID being about cutting corners, which it's not. What really has happened with the COVID vaccine is several things are happening in parallel. One is that FDA and other regulatory agencies around the world provided some real clear guidance about what they expected to see before a vaccine would be approved for emergency use or more broadly. Then there was an intensive effort by the companies working with the National Institutes of Health and other groups to do studies that would normally take a long time and because it takes longer to enroll people or not enough resources devoted to it. Again, not to cut corners, but to do more work quickly and in a coordinated way. We're now seeing the consequences of that with some clinical trials that have been set up quickly, but with FDA standards and very large, 30,000, 45,000. J&J, which I'm on the board of, is about to start a 60,000 person study of their vaccines. That's big numbers that are appropriate to determining whether a vaccine is really safe and effective for the range of people who could use it. And then in parallel with that, we're also seeing big time manufacturing of vaccines, not because we're necessarily going to use them. We don't know if these are going to work yet, but just so they'll be ready without more delays as production happens. And as we're seeing with the flu vaccine, it takes months to make many of these vaccines. So all of that's ready to go, or those are parallel steps which is going to make it possible, if the vaccines work, to have much more rapid access. And where the emergency use authorization comes in is that it gives the FDA an ability to be flexible, not just to approve a product or not, and potentially make it available to everyone, but to approve a product when they have enough evidence on safety and effectiveness to conclude that it's okay to use it for a select group of people who are at very relatively high risk and who could benefit the most from a new vaccine. So what does that mean is going to happen? Well, FDA has been pretty clear about this. For those of you who are joining us today who didn't see it, we had an event at Duke-Margolis last Thursday. It's on our website with the scientific leadership of the Biologics Center at FDA that's overseeing all this work, where they laid out exactly what they expected to see happen from here. And we want to watch to make sure that does happen, but it reflects a really good scientific process with finishing the studies. They're overseen by an independent group called the Data Safety Monitoring Board. So they're looking at the data. Not everybody else gets to see it. It's a blinded study, but they're looking at the data as it goes along, and they're not going to even end any of these clinical trials until they reach the conclusion that vaccine did have a significant effect on number of infections and severity of infections or not. At that point, the company would have an opportunity to apply for an emergency use authorization to the FDA. And at that point, FDA has said they're going to have a public meeting with their independent advisors on vaccines, where the company would present data, and this would all be in writing and shared with the public. The FDA would present their views on whether or not they think, or what they think of the data that they've seen, whether it's appropriate for use in the people who could benefit the most based on what the vaccine shows. Then there will be a decision about that. And then before there's any actual use, the Centers for Disease Control and its advisory committee on immunization practices would also provide guidance on how and in whom the vaccine should be used based on the FDA's regulatory decision. What all of that means is that first, we're going to have to see a safe and effective vaccine based on data on tens of thousands of patients, both safety data for at least a few months, and most of the serious events associated with a vaccine, they generally occur within the first 6 weeks. And we're also going to have to see that the vaccine really works in patients who would be in these early use cases. Those early use cases, that's what I think when people talk about vaccine being available late this year, they do not mean for everyone. They mean for the groups that are most likely to benefit based on the clinical trial evidence, and then potentially broader access after that. The groups most likely to benefit are likely to be healthcare workers. They're on the front lines. They have significant risk of exposure to the virus. And so it's really more like a therapeutic for them. We're not talking about trying to get to herd immunity. We're talking about trying to protect the people who are most likely to face a COVID-19 infection, every day of their lives because of the work that they do and the situation they live in. So healthcare workers, other essential workers who have had high rates of COVID to date. That includes a lot of lower income individuals and people from community of color, perhaps. And it also potentially includes the people who have faced the most risk when they do get COVID-19, like elderly nursing home residents, but not everyone, kind of a limited group where we have the clearest early evidence that meets the FDA's gold standard of a safe and effective treatment. Then the clinical studies that started with those tens of thousands of people will be continuing on for a number of additional months while this early access is going on. We'll get more data on safety from people who were in the clinical trials and more data on effectiveness. We'll also be able to get data and learn more from the thousands, hundreds of thousands, maybe a few million people or more who are getting the early access to the vaccine. And it would only be later, after we've got a bigger vaccine supply, after we've got this additional evidence, that I would expect to see more Americans having access to vaccines. And that's why I've heard a number of officials who are involved in vaccine development talk about vaccine being available potentially late this year but not widely available and not widely used, not to the point where we can think about, having large levels of immunity to the virus and really moving beyond the pandemic until well into 2021. So this is going to take some time to get the vaccine out to so many people. You got some other vaccine experts on the call who know how hard it is to get the public aware of how the vaccine might benefit them, as well as understanding the risks. And we've got a lot of education to do there. We've got a lot of distribution work to get out to all of our communities all over the country as we do develop this additional evidence, as we take and as we go through this staged approach. So this is going to be a big challenge. It's also going to take some time to get through the stepwise distribution, the additional evidence that's going to come on top of these big, well-overseen clinical trials that are going on now to get to broad vaccine availability. And very important for the public to understand that FDA has put in place, I think, a quite effective approach under this emergency circumstance, using emergency use authorization as a step on the way towards broader access to the vaccine. And I think also very important for the public to understand that we don't know the results of the trials yet, but there will be a lot of opportunities to learn, for them to learn, for their clinicians who they trust on these issues to learn more about exactly what the risks and benefits of a particular vaccine are. And I hope as a result, people are going to not rush to conclusions now about whether they want to get a vaccine or not, but pay attention to the process that's ahead so that we can all make good, informed decisions so we can move beyond this pandemic as quickly as possible, but while paying a due attention, important attention to the safety of the vaccines along the way.
Thank you, Dr. McClellan. That was very comprehensive. I'll let you take a breath now. Professor Vasudevan, I wanted to come back to, Dr. McClellan mentioned this nervousness, and obviously you study vaccine hesitance and reluctance, and we've seen, this kind of growing anti-vaccination movement in the last few years. But are you concerned that because people might perceive that this process is being rushed, that this might cause hesitancy in people who are otherwise pro-vaccine and very keen to get vaccinated?
Yes, Greg, that's a great question. And in fact, we are already seeing that. So we are seeing people who are normally pro-vaccine express concerns about the COVID-19 vaccine and not being comfortable with the way the vaccine is being pushed to market. I think this brings us back to the issue of vaccine confidence. When people are trying to make decisions about vaccinations, they often make risk-benefit trade-offs. Because this is a new vaccine, the risk aspect of the equation is very exaggerated. Right? We don't know what the vaccine is going to look like. We are seeing a process that's happening so fast. But I think one thing to realize is we are not in a position to do science as usual, because science as usual takes decades, right? So we are not in a position to do that. As Dr. McClellan described, we are making adjustments. We are using the tools in our toolbox. We are using our knowledge from related diseases, related vaccines, to kind of speed up the process of vaccine development. It doesn't necessarily mean that we are cutting corners. We are just being very efficient with the way that we are conducting this process. When we are discussing safety, I think a lot of people are confusing safety as safety about specific vaccine candidates. And this is in some way putting the cart before the horse, right? Because as Dr. McClellan mentioned, we don't have the safety data yet. So we really cannot say whether one vaccine candidate is better than the other. We really cannot say that unless we have data from all the trials. I think a lot of the concern really stems from the rush to approve the vaccine rather than the concern about specific vaccine candidates themselves. And I think the only way to get past that is to reassure the American public that all safety precautions will be followed, that the FDA has minimum standards that will be met. And the approval process really has to be transparent, it has to be reliable, and I think people are looking for a process that's free from political interference. There's just no two ways about it. And any shortcuts or any perception of shortcuts will really affect the public's trust in the vaccine. So it's actually going to be counterproductive. So the areas where we typically tend to focus on is trying to educate people about the vaccine, its safety, and its benefits. Because we don't have that data yet, what we are focusing on is really trying to tell people about the process, right? Educating people about the process so that when the data becomes available, they're able to look at the data and make an informed decision.
Sure, that makes perfect sense. Professor Denny, a question we've had from a reporter in the chat is that we hear all sorts of timelines out there from a few months to maybe 2 or 3 years. What kind of feeds into that? Why are the estimates kind of all over the place? Are people just talking about different things?
My sense is that it goes from what we think we're going to learn within the next few months, that the efficacy trials that are underway for the 3 big trials right now, we think we will learn some data that says they're promising vaccines. That's step one. Once you have the efficacy data and you have a safe vaccine to move forward with, the distribution part of it takes a long time. And some of these vaccines are going to be a little bit more challenging than some of the vaccines we've administered in the past. The cold chain requirements may be a little bit more of a challenge. So I think where the confusion starts to build from is where you heard Mark talk about, once it's approved, then you have to get these vaccines out, and there will be probably some sort of triaging where those, maybe first responders are first in line to get access to the vaccine. Perhaps those that have some underlying medical conditions are second in line, or, early in line. And then as you start to get coverage in those groups of people, then you move out to the general population. And that's not going to happen, at least in my opinion, over a few months. It's going to take some time, and then you're going to have the typical vaccine hesitancy. You already hear that people are hesitant to take a vaccine. Some people may just sit back and wait and see if, as other people are taking this vaccine, are they hearing that there's no adverse events happening, and they think it's safe. And then you may see the vaccine take rates grow over a period of time. So I think that's what adds to the confusion of whether it's going to be in January, July, or next year this time.
Sure, absolutely, that makes sense. Dr. McClellan, I'd like to come back to something you mentioned about the flu vaccine earlier in your remarks. You said that it could be a great warm-up for the use and distribution of the COVID vaccine. What for flu season, what does a great warm-up look like to you? What would you feel in terms of the flu vaccine distribution and penetration? What looks like a great warm-up? I think you're muted.
Yeah, sorry about that. A good sign would be if we can get flu vaccine rates up. Typically they're only around 50% and not that high, even in groups that are at highest risk, which is somewhat different from the groups that are at highest risk for COVID, but both include older individuals and healthcare workers, for example. So that would be one important sign. I think another is that we're going to need a lot of new distribution channels, not immediately when the early stages of vaccine become available. HHS has already made clear that they're going to be doing a very select and end-to-end distribution system for this early phase when there's only a limited vaccine supply available and when it's only been approved for a limited set of people for use in this pandemic emergency. But as we get to broader use with more of the public, we're going to need to bring in a lot of partners. So this is true for flu vaccine, where not just doctors' offices but pharmacies, which have really expanded their role in COVID testing, they're also looking to be helpful for COVID, broader access to COVID vaccination. So they've got good access to flu vaccine support now too. Special community health centers, maybe special programs set up at workplaces and elsewhere. Another important difference between the flu vaccine and COVID is that the COVID vaccine initially is not going to be used in children. That's not what we're focusing on studying right now, since they don't have the most severe cases, not the first groups to get vaccinated. So that's a bit different than flu. So, immunization steps in association with school, going back to school are probably not going to happen for COVID like they've happened for other vaccines. But there are a lot of workplaces that are now putting more of an emphasis on requiring a flu vaccines, a public health measure to help prevent not just spread of flu, but as you heard earlier, help prevent spread of symptoms that look like they could be COVID, and they're going to be more disruptive in the context of the pandemic. So those are some signs I think that would indicate that we're doing a good warm up for what's ahead with especially the large scale COVID vaccine distribution that may be coming if we get good results from these well-designed clinical studies, and if we get good data on the many people who are going to get earlier access to the vaccine. If all that looks good, we've got a big job ahead for making the COVID vaccines available in 2021 to a large part of the US population.
Sure, thank you very much. Professor Denny, I'd like to come back to you, but I'd also like our other panelists' take on this if you have anything to add. We've had a question in the chat asking what we know about the possibility of having co-occurring flu and coronavirus infections in the same patient. Can people get sick with both simultaneously? And if so, how much worse could it be than just having one of the infections alone? Do we know much about that yet?
Well, fortunately, I don't think we have seen it much in the US yet, but yes, dual infections are a significant risk. And that's one of the reasons I think we're all pushing for a high uptake, if you will, on flu vaccinations this year, is to try to minimize that. And again, I think earlier we were discussing, each of these infections affect the respiratory tract, can bring with it significant damage. So if you think of layering one on top of each other, it just makes it could make it a lot more devastating for people that do have dual infections. So anything we can do to minimize risk with both diseases. And I want to come back to, again, what I said early on, vaccines, yes, but we have social distancing, masks, all that can help with both of these infections as we're going into this season.
Gotcha, thank you very much. If neither of our other panelists have anything to add on that, we'll move on to another question here. Excuse me. And actually, Dr. Denny, this might be one for you to tackle also. Given that we've never had a vaccine for the common cold, which is another in the family of coronaviruses, if an effective vaccine is developed against COVID-19, does that mean there is any hope for a vaccine against the common cold?
Well, so coronaviruses come from are in a number of families. And, what we're dealing with the coronavirus, SARS-2 now, is what we classify as a novel coronavirus. And, common cold vaccines have been a challenge for a lot of years because that bug mutates it drifts, if you will, or changes very rapidly. So it's been a very hard bug to chase. One of the programs at Duke, and Bart Haynes that leads the Vaccine Institute, has a program right now that we are looking to develop what we are calling a pan-coronavirus vaccine. And this may help us. We're aiming it initially at there are a number of other potential novel coronaviruses that could hop to humans. And if we can think of having a vaccine that, if you think of a trunk of a tree and the branches and the leaves, sometimes we make vaccines, if you will, to the leaves or the branches. What we're trying to approach is make a vaccine to the central trunk of that family of viruses. If we can do that, we may be able to minimize the risk of a number of coronaviruses, the family of coronaviruses. So the hope is, yes, that we can do something. The science is not there yet to prove that we'll have it, but we're on an aggressive path to try to show that we can come up with some innovative approaches to minimize the risk for this whole family of viruses.
Just to add a little bit to that, the vaccines that are being tested now for COVID are not really sort of trunk vaccines. They're aimed at generally the spike protein and some antigens that are specific to the COVID-19 virus. And I think the hope here, as you probably highlighted and you all have heard before, is not that this is necessarily going to be a slam dunk, prevent every case of COVID for the future, but really reduce the severity, have enough of an impact that COVID becomes much more like a common cold without the serious complications and with much milder symptoms. We don't know yet if the current COVID vaccines are going to be, how long they're going to last, whether they're going to eliminate cases or just, FDA has said as their minimum goal, it's got to be at least 50% effective in reducing the severity of cases and the number of cases. That would be a big step forward, but it's not going to get rid of the COVID coronavirus. It's going to make it more like a cold, hopefully.
Yeah, that's a good. What we fail to recognize sometimes with this, we've come a long way in 6 or 7 months. And if you think of the challenges, if you go back in history and look at how long it took to develop vaccines to prevent a lot of infectious diseases, I mean, there's history to show that some things took several years, some things took 10 years or 15 years to get vaccines developed to help reduce infectious diseases. So in 6 months or 7 months, to be at a point where you have a number of vaccine candidates that are in efficacy trials, that's an enormous leap forward from what we've done in the past. I think that's a combination of technology we have today that we didn't have 15 years ago or 10 years ago. But it's also a credit to the urgency that the field has brought to this and said how serious this event is, this pandemic, and how we have to work together and come up with innovative approaches. They're not going to be the initial ones are not going to be the home run balls that we call them, or the grand slams. There'll be incremental changes or improvements that we'll build upon over some years, I think. But I think we as we criticize a lot of times of, we're moving too fast, or this is not right, or that's not right, or we've tried to focus on all the negatives associated with some of it. There's been an enormous amount of science that's been learned in a very short period of time, and an enormous amount of progress in terms of getting somewhere to turn the curve, if you will, of what we've all been faced with the last 6 months.
Thank you both very much. It's good to know that there are reasons for optimism. Professor Vasudevan, I'd like to come back to you in this notion of vaccine resistance. There's some new research from Duke that found that only 1/3 of American adults received the influenza vaccine in 2018. And it found several demographic factors, including being male, being Black or Native American, or being uninsured, that predicted lower rates. Do you think that for the flu vaccine and for the upcoming COVID vaccine, whenever it's ready, that we need some kind of targeted interventions to address specifically some of those demographic issues to get the rates up in those particular areas? And what could that look like?
Yeah, absolutely, Greg. In fact, it worries me a lot that communities that are the hardest hit by COVID are also very heavily impacted by flu. And we know that vaccination rates are lower in these communities. I think first we need more research, like the one paper that you're citing out of Duke, to highlight, susceptible communities, to identify communities that need to be prioritized, but also to identify best interventions to address the concerns that they have about vaccines. Because a lot of these communities have a long history of negative experiences with healthcare and research and distrust in authority. And it's just becoming so much worse with prevalence of misinformation online. And that's just fueling anti-vaccine sentiments. So I think we have a long way to go in terms of regaining their confidence and trust. And any interventions that we think about in terms of prioritizing the vaccine or prioritizing education, communication, really need to focus on building back that trust. And I think at the policy level, we need more research funding to understand how best to do that. But through all of this, we really need to work with local community leaders. We need to have strong partnerships, because this is not something that will happen if it's top down. I think we really need to be at the grassroots level, working with the communities in order to identify the best ways to get the message across.
Sure, thank you. Dr. McClellan, somewhat related, we've had a question that's a little bit off piece, but now seems to be the time to bring it up. We've seen, obviously, even just in North Carolina, that the death rate from COVID is higher in rural counties than it is in urban counties. What kind of effect is geography and the urban-rural divide having, on the availability of what treatments there are for COVID? And do we expect to see flu season be worse in those areas too?
Well, I hope it doesn't reflect the availability of treatments too much. As we've just been talking about, it's very important to get the treatments that are coming. So it's not just vaccines, hopefully more progress on things like synthetic antibodies that are targeted against the COVID virus, and more treatments for people who have severe complications like blood clotting problems or these severe immune reactions that really compromise their ability to breathe. We are getting better and have some potential treatments and trials for improving outcomes in that context too, and we'd like to make those widely available. The biggest challenges with rural communities and with communities of color and other disadvantaged communities has not just been treatments, but also risk of exposures for people who are in jobs further in close proximity, like a poultry processing plant or something like that, or don't have the ability to isolate if they are exposed to someone who's been infected. So we need to take more steps. We talked about the importance of masks. Masks have had a bigger effect than flu vaccination in many countries already, as you've heard about before, on suppressing the spread of a virus. So we need to pay attention to that in rural and other communities too. And as vaccines become available, it is very important to have a plan that gets those vaccines with good information to the trusted voices in the community, physicians, health practitioners who are working there, other community leaders, gets that out to every part of North Carolina and every part of the country. We're not going to get beyond the pandemic until we get accessibility for COVID vaccine. We're aiming for zero cost, accessibility at zero cost for everyone who can benefit, and good information to help them make informed decisions. So that needs to apply to rural communities, and HHS has asked the states to do a lot of the lifting to help make sure that can happen. I know North Carolina has already set up an advisory group to help them in developing this plan that can reach rural areas and can reach nursing homes and can reach communities of color, immigrant communities. This is a lot of work ahead so that we do not see disparities in the future, and so that we do get good outcomes from appropriate use of vaccines as they become kind of more and more available in the coming months.
Thank you very much. I'd remind everybody on the call that if you would like to ask a question, you can pose it in the Q&A window, or you can raise your hand in Zoom and we can unmute you so you can ask your question. If you happen to be joining by phone, you can hit *9 to raise your hand so that you can be unmuted. Professor Denny, moving on here. For the last 6 months, obviously, a lot of people have been working from home, have been socially distancing, have been wearing masks when going out in public. Could that lessen the impact of flu season? Is there a reason is that a potential reason for optimism this year, since we're already doing those things and will continue to do so? Could that prevent the transmission of flu, or are we talking about separate tracks?
No, absolutely. I mean, if you look at what's happened in the Southern Hemisphere, in Australia, for example, they've had a very mild season. And when I talk to colleagues there, they're attributing a lot of that to they've been on lockdown, they've been wearing masks, they've been following aggressive social distancing. So all of those, applications here in our flu season, I would predict would reduce the amount of flu transmissions or flus that we have. COVID and flu spread in many, in similar ways. So the respiratory exposure, and if we can social distance and mask, and we should see some benefit there.
Gotcha. Thank you very much.
If I can just add to that, I think there is some false sense of security though with that data. I think there's a lot circulating, especially online, about how the rates of flu have been really low in the Southern Hemisphere, but people are not really talking about the second part that Dr. Denny mentioned, which is, those countries really enforced social distancing. There was really good mask wearing. We haven't really seen that in the US in many different situations. So we have done really poorly in terms of implementing some of those safety measures. And even today, we are talking about reopening. how to get back to normal when really the risk of flu still exists. So, I mean, while I'm cautiously optimistic as well, I think it's important to recognize that there is a real risk of flu and there is no guarantee that our flu season will be mild. And if we really want that outcome, we really need to continue to enforce those safety measures, continue to do social distancing and masking. And that's the only reason why the rates have been low in the Southern Hemisphere.
And I build and then push for increased vaccinations. That's all part of it. It's you know, they're all tools in the toolbox that help to reduce the event of these infections.
Yes.
Thank you both. And Professor Vasudiphan, I'd like to stay with you for a minute. It's interesting when we look at the potential for flu vaccination rates this season. There are so many factors. There are the fact that many people are staying home and not getting regular medical care, but there's already more of a push towards vaccination. And anecdotally, I'm seeing more people say, "Hey, I want to get my flu vaccine shot this year." You know, you want to be part of the team. And then there's also that reluctance out there, and all of these things, you know, are feeding into are going to feed into the final number of flu vaccinations that we get. Based on what you see in your research, do you expect that ultimately it will all wash out to be roughly the same rate that we normally see? Or do you think there is potential for greater flu vaccination or a risk that the rate will actually be lower than in past years?
Yeah, it's actually really hard to predict. I am hoping that the rates will be much higher. Like I mentioned, the state is really, it's launched a really aggressive educational campaign. There's education being done on social media, but there's also way more misinformation out there than there was in previous years, and really targeting flu and COVID vaccines. So I'm waiting to see which way the rates are going to go. I think it's really hard to predict. We are really hoping that it's going to be much better. That's the outcome that we are all aiming for. And I think we have talked a lot in this briefing about why getting the flu vaccination is really important this season. So hopefully anybody that's hearing really recognizes the importance of that and gets vaccinated. That's really my hope.
Splendid, thank you. We've got a few minutes left here, and we're having a number of questions that orbit around the same topic. And Dr. McClellan, I'd like to come back to you for this. Is that obviously there are lots of concerns that the development or the approval of a COVID vaccine will be politicized in some way. And certainly, regardless of the result of November's election, we're still going to be a polarized country. There are still going to be people that don't necessarily have trust in the government, regardless of who's in charge. What do you think can be done to assure people that you know, the FDA is being thorough, is not being unduly influenced by any kind of partisan politics, and that people can be confident that a vaccine that when it comes out is effective and safe?
Yeah, this is a really important question and a really important topic for public health. You know, we are in peak election season. It is a divided country on many political issues. That does not need to go, though, to how we are actually developing and using vaccines. And while I know, you know, I see this in the chat too, politicians, press people have made a lot of statements about the vaccine that understandably have raised some concerns about the integrity of the scientific process here. Just remember that press spokesmen are not in charge of the process, and we have a very well developed system for clinical trials in this country that has all kinds of integrity steps built in. So since we don't have any results yet, as Lavanya said, there's going to be a lot of speculation about cutting corners and things like that. So I think what people need to focus on right now is what's going on with the actual process. Is there any indication that the trials are being compromised, that the evidence being developed isn't sufficient? Soon, we will hopefully have some data that people will actually be able to look at to see what we're actually learning about the vaccines. And all of that's going to happen before anyone needs to make a decision about whether they get vaccinated or not. So right now, for clinicians as well as for the broader public, the proof is in the process. There are clinical trials that are being conducted with independent experts, overseen by the National Institutes of Health scientists, overseen by the FDA scientists, overseen by independent academic experts. So the first thing to watch is, do those trials continue as they've been set up and with the control of this data safety monitoring board? That's a technical term that basically means an independent group that observes how the trial is being conducted and that makes a first determination whether the trial's actually been completed. Has it gotten to these really important endpoints of learning whether the vaccine in a well-designed randomized trial actually reduces COVID infections? So that's the first thing to watch, and we'll be able to see if that happens within the next month or two for some of these trials that started early. If we don't get to that stage, if someone else comes in and shuts down the trial or tries to act before we have those results, that would be a reason for concern. That's one thing to watch. Second thing to watch is that the FDA career expert scientists have said that they are going to publicly present and have an independent review of the data from these trials before they make any decisions about an emergency use authorization or any kind of access to the vaccine. So second thing to watch is, does that process occur, and is it transparent and public? At that point, we'll actually have a lot of data, a lot of evidence to look at that we can use to judge whether FDA and the scientists and experts at CDC that are part of their immune advisory committee, which is also going to have a public meeting and review and writing some of these data, are making reasonable decisions. I don't see any indication that they won't. These are people of considerable integrity. There are a lot of them. No one group or individual can hijack has ever been able to hijack this process before. I know people are concerned because we are in unique times with this pandemic and coinciding with this very contentious election, but those are things to watch now. The proof is in the process. So the steps that I talked about that you will see happen over the next few months, I predict, and if we don't see them, then that is a reason for concern. But I have a lot of confidence in our clinical trial process in this country, and a lot of confidence in the career scientists at FDA who have been very clear in public that they are absolutely committed to doing the right thing. I know people have also, and I saw this in the chat too, have raised questions of, well, didn't FDA authorize emergency use of hydroxychloroquine or convalescent plasma? And that's true. And I want to go back to explain about some of the basic features of emergency use authorization. That does allow FDA to make judgments based on all of the available evidence at the time. And those judgments, though, have to be guided by what's in the best interests of the people who would be using the product. Hydroxychloroquine had its emergency use authorization withdrawn because the evidence suggested, additional evidence suggested not only no clear benefit, but some potential harm. So that's out. And hydroxychloroquine and the convalescent plasma approval, for those of you who are following that, that's for a very different population. That's for severely ill, hospitalized patients. For a convalescent plasma, we have a lot of experience that it's safe. I don't think the evidence is very convincing that it has a benefit, but there's some suggestive evidence, and there are more studies going on now. But that's a very different situation than for a vaccine that would be given to a very large number of people who are healthy, not hospitalized patients. And a vaccine, unlike convalescent plasma, is not a treatment where we have a lot of experience that it's safe. So that doesn't meet the emergency use authorization standard. It's a very different case, very appropriately much higher standards for FDA that they're going to apply here. So we will have a chance to watch all this as it goes along. There's going to be a lot more noise and the like around these issues, I have no doubt. I encourage people to watch closely what's actually happening in the clinical studies, what's actually happening in the scientific oversight of this and the regulatory oversight of this process as we go forward. Hopefully, who knows if the vaccines are really going to work or not, but I have great confidence in the staff at the FDA, the staff at NIH, the independent scientists who are involved in all of this to not only do this right, but to be transparent about it as we get through these next critical weeks of better evidence, hopefully, on COVID vaccines.
Gotcha. Thank you very much for that comprehensive answer. Professor Denny, I'm curious, we've seen, as Dr. McClellan mentioned, all of the pronouncements coming out from the FDA and then a lot, going on politically. Do you, at the moment, based on what Dr. McClellan's saying, the stuff that you're watching, do you have confidence in the FDA process that it's not being politically tampered with unduly and that the steps will be followed so that we will get a vaccine that has been thoroughly tested whenever it's approved?
Yeah, I would just build on what Dr. McClellan mentioned. You know, the FDA is, if not the best, it is at the very top of the most talented group of people in the world that have regulatory oversight over a number of different types of products. And while, yes, there are political appointees at certain levels, there are thousands of staff level scientists that are incredibly talented and have their scientific reputations at stake when they review drugs, vaccines, medical products. So I have no doubt that that group of people are going to do their job. I agree with Dr. McClellan. The more transparency we have there, the better, so the public can see this. But it's going to be contentious. We're not even at that point, and it's contentious today, just a speculation of where we're going. And the other part I guess I want to focus on, while there is criticism about an EUA process, you know, let's just look at, we're in a war. We have a bug that's coming after us. We're having lots of infections and deaths. A traditional path to approve a vaccine, if we were looking, you know, outside of a pandemic and an EUA, maybe 2-3 years or more. And I think if we knew we had a vaccine that has a level of efficacy that we may get coming out of some of these trials right now, and we're not to go down an EUA route, I think that would be irresponsible also. So I think there's a balance there between, if you will, the fastness and yet being, you know, too slow and not being responsive to the emergency that we are in. And there's no doubt about it. We're in an emergency. Just look at the worldwide numbers, look at the number of deaths, look at the issues of having to shut down an economy, can't get kids back to school, all these sorts of things. So we do need some help here. You know, I'm also, what I would like to see is just as much focus on the development of treatments. And hopefully we don't hear a lot of other opportunities coming for drugs. But if we can get a few more treatment options in the toolbox, then the vaccine is just, you know, it's another part of it, but we can take care of those folks that get infected and have adverse paths with their disease, and hopefully have an antiviral drug that will be able to be administered early on, or at least if they are starting to get into severe complications, and change that trajectory. So, you know, again, vaccines, masks, these, you know, there's a number of tools that we need to deal with this effectively. And I think if we can get a number of those, then we're on the road to getting back to whatever normality was prior to the beginning of 2020.
Sure, thank you. We'll be wrapping up here in a minute, but Professor Vasudevan, I wanted to ask you for your take. You know, we've heard a lot there from Dr. McClellan and Professor Denny, and you study, you know, vaccine reluctance and hesitance. Do you think that it's possible that a focus on the process can kind of cut through the noise, especially all of the misinformation that circulates on social media? What do you think that the most important thing for the FDA and vaccine makers to do, if there is a most important thing that they can do to cut through that and assure people that this is a vaccine when it's ready that they need to get and that will be safe and effective?
Yeah, look, I think what we know from our research is we cannot change everybody's mind, but I think really where we are focusing on is people who are on the fence, people who are otherwise pro-vaccine, believe in the process. And I think what they are looking for, from what I understand, is just this reassurance that the process will have integrity. So I think some of the things that the other panelists mentioned in terms of making this process really transparent, educating people about the process so that when they have the data, they can really understand what the risk-benefit trade-offs are, and recognizing, as Dr. Denny said, that these are really unusual circumstances, and that we would, you know, this is a process that we really need to use from an ethical and moral perspective for preventing additional deaths and really trying to stem this pandemic. But I think at the base of all of this, I think with more reassurance and more transparency in the process, I think we can convert a lot of people back in favor of the vaccine.
Gotcha. Thank you very much. We are just about at time, but before we go, Dr. McClellan, I'd like to come back to you, and I'd love for the other panelists to weigh in if you have anything to add. Assuming we trust the process here and we focus on the things that you're talking about, everybody wonders about timelines. What do you think, assuming that we get an emergency authorization once a vaccine is shown to be potentially ready for use? What kind of timeline should we expect frontline people to start getting this, and what could the general public be looking at in terms of a rough kind of timeline before a vaccine was generally available, or is it too early to say?
It's too early to say for sure, but let me also say that it's not just a question of trust the process. This is another trust but verify, right? So we talk about steps that people should be looking for. Basically what the FDA expert scientists have said that they intend to do, and what the people who are the independent researchers who are overseeing the trials have said they're intending to do. Let's make sure that happens. So it's a good process. We need to make sure it happens. In terms of when vaccines will be available, first of all, we have to see what the results of the trial are. If the vaccines do show a significant enough benefit, then it is possible, based on the timeline for the trials, and again, this depends on things like, most importantly, how safe and effective the vaccine actually is, but also things like how many COVID cases are occurring in the communities where the trials are being done. Some of these are being done in places where there were lots of cases back in July and August, not so many cases now. If there's not that much COVID, then it's harder to tell if the vaccine is really having an effect on cases. So that's why there's a lot of uncertainty in these predictions. And if anybody tells you they know for sure, they don't. But all that said, if the trials go forward as expected, and if they accumulate as an expected number of events, and if the vaccines are reasonably effective, we could have results out from the trials by, I don't think before the election, by, November timeframe, some of those public meetings that I talked about. And that could mean some access to the vaccine under an emergency use authorization by the end of the year. But different vaccines are on different timetables, and so this is going to be a gradual process. So maybe some use by late this year, some additional vaccines online in 2021. But as many experts have said, including Tony Fauci, probably not broad access for the American public till later in the first quarter, second quarter of 2021. And even then, as we've talked about, some big challenges in making the vaccine widely available and widely used. So this is probably we're not going to get out of the pandemic until we have not only safe and effective vaccines proven, but that they're widely used. So that's going to be well on into 2021.
Thank you. And I think we'll leave it there. This was a very substantive discussion. Thank you so much, everyone, for joining us. Thanks to our panelists, Thomas Denny, Mark McClellan, and 𝐲𝐬 Vasudevan for sharing your perspectives. Next week's briefing, we'll be pivoting back to racial justice, and we'll be discussing civil rights protests and white nationalism. If you'd like to attend that event, please email news@duke.edu. In the meantime, please stay safe and well. Thanks, and have a great weekend.